Hi, my name is Andrea Stallworth, and I am getting ready to do a YouTube video of my portfolio. I'm doing it a little bit different because I'm not savvy with the computer, but I can do a PowerPoint, but I just can't do the other stuff. And so don't judge me, no judging. Anyway, I'm going to go with my table of contents. My table of contents has my resume, my HIA certifications, my professional accomplishments, my PDSA project, and my 5-year professional plan. Okay? So, my resume, I actually did put together a portfolio. My resume, which is right here, has my resume, and it's 2 pages. And then afterwards, you'll see my IHI certification. So this is 101, 102, 103, 104, and 105. Now for my PSDA project, this project was a project to reduce the wait time for surgical treatment, as well as improve the communication between departments. Right now, a lot of cases are being delayed because our process changed. How direct admit patients were being admitted to the hospital, the ones for surgery, as well as patients coming downstairs and not being NPO, not being properly prepped for surgery. So the hospital came up with this surgical checklist for nurses to use. However, the nurses are not using the surgical checklist, and as a result of that, it's causing the patient anxiety, it's costing the OR money, and everybody's upset all around because every time we receive a patient in surgical services, and they are not properly prepared, we do an incident report. So right now, the only communication between the two of us are usually incident reports. So the first thing I did was I started shadowing a young lady by the name of Summer. Summer was the manager for several units up there because I work at a small hospital. And I just walked around with her. I started making rounds, introducing myself to the staff. And the first few days that I spent with her, I spent the time sitting at the computer as she spoke to each incident report concerning patients who were not prepped for a procedure, whether they were going into interventional radiology, or they were going to have a surgical procedure, or they were going to the cath lab. They were sent down because they were not kept NPO status. They did not have the critical labs that they needed, say for instance, if they needed to have their troponins drawn, or if they needed to have their potassium drawn, if they needed to have a pregnancy test done. So all of those things were setbacks. Or if the patient had any kind of implants in them, when they come down to surgery, if they have a pacemaker, or a defibrillator, sometimes the doctor would like them to have the rep there to interrogate the pacemaker or the AICD. But if it's not filled out, we don't know that information, and sometimes they require a little bit more notice than just the 30 minutes before they get ready to go into surgery. So the first thing I did was look up a theorist, and the theorist that I looked up, his name was Kurt Lewin. Kurt Lewin is responsible for the theory of change. And in the theory of change, he has a 3-step change model. Unfreeze is the first step. Unfreeze is when you try to get people to stop doing what they're doing, and you're getting them ready for the change. So part of that was meeting with the educators, the managers, the charge nurses, as well as any change agent, any nurse leader on that floor that was willing to meet. I sat down with them and I talked to them about the whole Lewin project, and trying to get their support because I knew I couldn't do this on my own, and to get their buy-in. And actually, the educator decided that it needed to be a mandatory educational in-service given. And so that was the first thing we did. We did a mandatory in-service. We gave 2 dates for them to go to for evening shift as well as night shifts to ensure that all the staff will be able to make it. And during that in-service, we also they had computers laid out where they can actually go in and sit at the computer. They were given the statistics of what happens, cost-wise, what happens as a delay of surgery, things that can happen as a delay of surgery. It can cause something severe as from increased hospital bill to death, depending on how severe it is that they would miss surgery. I have a copy of the checklist here, and it's actually not as long as it appears, but it's 3 pages because of when I snapshot it at work, it wouldn't fit all on 1 page. So it asks questions like what the procedure is, but as you start to go down the checklist, you may not be able to see because the writing is so small, but they ask questions about their any kind of implants. Do they have contact lenses in? The IOLs in? Do they have any kind of jury? Any hair removed? Hair should never be shaved in the OR. It should be shaved either in pre-op or it should be shaved on the unit before the patient comes down. What's the patient NPO? Was the patient on any kind of anticoagulant? And most of you know, if you've taken care of any patient that is going down for surgery, they need to be off their anticoagulant for 7 days. A lot of times they have not been off of their warfarin, or they haven't been off of their Eliquis for 7 days. And so as a result, they come downstairs and then the case winds up being canceled. Did they get the proper prep? If they come down for a colonoscopy, were they able to finish their prep? Was the stool nice and clear when we come to get them? Many times we go upstairs and get them, we come down there and they've only just been drinking the liquid for maybe an hour and they haven't even finished it. So it's been a real problem. But anyway, we had it in service and during the in-service, one of the things we wanted to do is to teach them how to stop the behavior that they were doing, which the behavior was to not to fill out the checklist. So we were at the unfreezing stage. Also, there was a survey that was asked. It was handed out when they came in for the educational in-service, and it wasn't a heavy questionnaire because we didn't want to overwhelm them, but it had, the first question was, how often do you use the surgical checklist? Always, sometimes, and never. And if you're not using it, question 2 was, why are you not using a checklist? Do you find it time consuming? Is it not beneficial? Is the information redundant? We know a lot of times when we're charting that we see stuff that we chart 2 or 3 different places. So sometimes nurses don't do it because maybe they feel like it's redundant. Is it nothing wrong with my current practice? Sometimes they just don't want change. Did not know I had to do it. Do not like change, and then other. So they could write in what they wanted. The next question was, after the in-service, how certain are you that you will implement the checklist into your practice? Are you certain, not sure, maybe, or I will not implement it? And then there was any recommendations. We had a couple of recommendations that asked if it was any way possible that when a patient, doctor put in orders for the patient to have surgery, if the alert would come on, a task would come on their task list asking them to do the surgical checklist. The next phase that they would go to after you undo this was stage 2, which is movement or change. That is to get them to start doing what you want them to do, and that's filling out the surgical checklist. So I started monitoring the nurses and started working with them. I started out with the newer nurses because they had a lot of graduate nurses that were new and they just weren't being taught to use it. So I worked with them first because they were eager to learn. They asked questions. They found that the checklist was really helping them because they didn't know to ask, what questions to ask. They didn't know how to prep them for surgery, so this was really good. Some of the older nurses kind of kicked against the prick and just did not want to change and thought that their way was the only way and they weren't going to change, or nothing was wrong with their way. I remember this one particular nurse, I had to, when I first came up, she was one that I observed. She didn't even look to see. I said, do you mind if I look? And she said, I don't care. The nurse that I got the patient from, she probably did it already. And she never looked, but come to find out that he was on an anticoagulant that had never been stopped. He had never been shaved, and he didn't have a test that he wanted to have, that he needed to have before surgery. So once we got the movement going and we got people involved and it was going fair, there still were a couple of people that just wasn't quite within it. And it just so happened, it was a day where they were very, very, very short. And this nurse in particular that I was following had been there for many years. She didn't want to do anything with the checklist because she thought it took a lot of time. So because I could see that they were really drowning, they were fully packed and just needed help. They didn't have any text that day. And so I suggested to Summer, who was the manager that I was following, to call down the surgical services and ask my boss if there was anybody available that could come and help out on the floor. Half of our staff, as a result, came upstairs, and while most of them did not have any kind of bedside care with patients, they were able to give baths, pass out trays, take patients to the bathroom, and help them back in bed, and just answer call lights. And that changed the whole relationship with surgical services and the unit, because we were able to form collaborative relationships to work together, and everybody just helped everybody, and they were very appreciative of that. And so as this young lady who I like to call Joyce, she got a surgical patient as a direct admit, and so I asked her, if I do the direct admit, will you do the surgical checklist? And she said yes. And so I did the admission database, and she did the surgical checklist, and she found that it wasn't as hard, as difficult as she thought it would be. And so she said she would start using it, and I just was really glad about this. This took me about 8 weeks. I actually spent about 48 hours instead of regular 32 because I was really passionate about this project. I was wanted it to work, and I just felt the need to have the push, and I wanted to encourage the change agents, the educator, as well as the managers and any of the leaders on that floor to show support while they were going through this, because they were short and they did have a lot of new graduate nurses. So there were times where they felt overwhelmed, but I wanted the staff to be able to feel the support so that they would keep that behavior going, which took us to the third step, which was refreezing, getting them back into the normal step. And things worked out really well. I'm really glad that I did this project, because as a result, I just think that not only was communication improved, but the delay of surgical treatment was reduced by 30%, and that is a huge win for the patients, and as well as for our staff. So I'm glad about that. As far as my professional accomplishments, I'm proud to say that in my BSN, I will have May 2nd. I want to say congratulations to the entire class of 2019. It has been a long journey. For some of us, it's been longer than others, but we have made it and we have arrived. And I just want to say, I hope you are just as proud of yourself as I am of myself. And God bless all of you in your future endeavors. I got my certification in my field in January of this year, so I am now a certified nurse of the operating room. I also got my CN3 last year, which added on more duties. I do the schedule now for the nurses. We take call. We work 5 days a week, and we take call as well, and we cover endo as well as our OR. I also this year, last month, as a matter of fact, became the co-chair of PPC, and I am the robotic coordinator for all the robotic surgeries that come through our department. I am a preceptor, and just recently, as a result of doing this project, our educator in surgical services left to start teaching at a college because she got her master's. And I'm happy to say that I was offered the position of educator, so I will be taking that position. And so that's why it was important for me to get that portfolio together. Now I'll talk to you about my 5-year plan. As I told you, I wanted to be an educator. I plan on going back to school in August of 2019. I need a little break in there first. And then I want to go to school for my nurse practitioner. And just recently, while we were in school and doing this volunteer work, I got a chance to volunteer at the Talbot House in Lakeland. And I'll tell you, mental health is so prevalent. And we just don't have a lot of nurse practitioners going into mental health. My husband suffers from PTSD as well as anxiety and depression. I have a niece that suffers from anxiety and depression. And I think that we need more nurse practitioners going in that direction. So if I can encourage any of you, if you haven't decided what you do, they do need nurse practitioners in mental health. Again, congratulations to all of you. You should be proud. I know I am. Thank you.